Very warm welcome to each one of you joining us live this evening. We are delighted to have you with us for Sneeze to Breeze, our Allergic Rhinitis Awareness Initiative, an effort designed to bring a sharper focus to one of the most common yet often misunderstood conditions in clinical practice. With respiratory allergies on the rise and patient quality of life significantly impacted, this Sneeze to Breathe initiative aims to facilitate meaningful dialogue, refresh clinical perspective, and strengthen day-to-day management approaches. We are honored to have with us two esteemed clinical experts in our very first session of Sneeze to Breathe initiative. So, without any further ado, I would like to welcome our clinical expert for today, Dr. Rupali Jain. Dr. Rupali Patil Jain is an ENT surgeon, allergologist, and a medical legal consultant. She has done her MBBS from Dr. PDMM College, Amravati, and her post graduation in ENT DORL from CPS Mumbai. She has been practicing in Varud district, Amravati, for the last 20 years. She is a co-editor of a book on allergic rhinitis and has contributed to a chapter on chronic rhinosinusitis. Ma'am is going to share her expertise on diagnostic modalities in allergic rhinitis. We welcome you, ma'am. With this, I would also like to welcome our other clinical expert today, Dr. Subir Jain. Dr. Subir Jain has done his post-graduation in ENT in the year 1987 from MGM Medical College, Indore, in Madhya Pradesh, India. He is an author of Handbook of Allergic Rhinitis and has India Book of Records under his name as the author of Handbook of Allergic Rhinitis for the distribution of maximum number of copies to the doctors across India. He is contributing actively to public awareness as author of many booklets on patient education as well as through different social media channels. Chik- Chikitsak Samman in 2022 and Atal Gaurav Samman in 2023 for outstanding work in allergic rhinitis. He has published and presented several research papers in prestigious national and international conferences. Sir is going to guide us about recent advances in the management of allergic rhinitis. We look forward to an engaging, insightful, and academically enriching session. With this, I would like to hand over the session to Dr. Rupali Jain to guide us, the people who have joined us today, and take the presentation forward. Thank you.
Thank you, Anjali, for the kind introduction. I will share my presentation. Hello everyone. I'm Dr. Rupali Jain, and my today's topic is allergic rhinitis, the diagnostic modalities. Of all the allergic diseases, the allergic rhinitis is one of the most common diseases of all the allergic diseases. So it's like 25 to 40% people are suffering from allergic rhinitis. And so this webinar today is an initiative to bring an awareness among the ENT surgeons as well as the other physicians as well as other healthcare professionals regarding the newer diagnostic modalities available as well as the treatments available. So today me and Dr. Subir are going to take you through this. Slide is not So coming to the clinical evaluation, as we all know that allergic rhinitis is a type 1 hypersensitivity IgE mediated disease. And so when we are doing the several atopic tests to diagnose the causative factor or the aeroallergens which are responsible for allergic rhinitis. So when we do the skin prick test, we get a certain report. We have to correlate this report with the patient's history. And that's why the history taking is very, very important when you first see the patient. Now, coming to the history taking, the first most important thing is the family history. Now, why family history? Because if a single parent is suffering from allergic diseases, any atopic diseases, then the patient has 40 to 60% chances. And if both the parents are suffering, then the patient has 60 to 80% chances of having a allergic disease. Perennial or seasonal. If the symptoms are perennial, then most probably the causative allergens can be the house dust mites or the animal danders or a cockroach. Whereas in seasonal, if the patient is having seasonal variations, then the tree pollens, the grass pollens, they are the common causative factors. Then the worst months. Now, if the patient, suppose the patient is saying that he is having a particular, his symptoms are more in the February, March or April. That time there is one pollen, that is holoptalia, which is very common in this western part of our country. And many patients come show sensitization to the holoptalia. So the worst month history is also very important. Now, place of residence. Some patients will give a history that in a particular city they are having symptoms. For example, I had a patient who, when he used to come to his village, he used to get the symptoms. And when I did his skin prick test, he came positive for Ricinus communis. When I asked the history, he said that in the village, in his house, the Ricinus communis, the seeds are stored. That is the erendi, which we call in our local language. It is called as the erendi. So the this history is again important. Then the workplace. For example, in the bakers or the farmers, they have symptoms when they go to their workplace. Pets in the house, dogs and cats. Many people now they love to have pets, but if you see the cat, the allergen of the cat is a very sticky allergen. So even if the patient does not have a cat in the house, the cats, they keep on roaming in the neighborhood and they leave those allergen proteins in our houses, and the patient can have symptoms. Dietary history. Some patients might be suffering from oral allergy syndrome. In such cases, dietary history is also very important. The personal history regarding smoking. The smoking, it can be a first hand, second hand, or a third hand exposure to the tobacco smoke. Similarly, if the patients, they are exposed to irritants, in our country, a lot of agarbattis are being lit in the house. Similarly, this mosquito coil, if you know that one mosquito coil will produce about chemicals of equivalent to 100 cigarettes. So again, the personal history is very important. Then if the patient is suffering from any comorbid illnesses, or if he is having any medication history, before doing a skin prick test, we have to know certain medications. Coming to the physical examination, we all know the patient will have a typical allergic salute over the nose, the allergic shiners because of the continuous venous congestion of the paranasal sinuses, then the Denny-Morgan lines because of the continuous the constriction of the infra or orbital muscles. The nasal mucosa, it will either be a pale mucosa, a bluish mucosa, or a polypoidal mucosa. The patient will have clear watery secretions. We should also see for any polyps, whether there is a septal deviation or there is any mass in the nose. Now coming to the in vivo tests, there are in vivo tests as well as the in vitro test. The in vivo tests are the skin prick test, the intradermal test, and the nasal provocation test. So the first, the most, important and the gold standard test is the skin prick test. The American Association, the European Association, even the World Allergy Organization, they have considered skin prick test as the gold standard test for the allergic diagnosis. Now, allergic rhinitis is an IgE-mediated type 1 hypersensitivity disease, and we know the pathophysiology. That is, first is the sensitization phase, and the second is the exposure phase. So when we are doing a skin prick test, we are testing the sensitization of the patient. So sensitization is an immunological state, atopic is a genetic state, and the allergy is a clinical state. Now, how do you select a patient for skin prick test? The indications are allergic rhinitis and asthma, food allergy, latex allergy, and atopic dermatitis. The skin should be a normal, healthy skin. The patient should be cooperative. And it is done from 2 to 60 years. Below and above that, the skin reactivity varies. Coming to the selection of the antigens, the most common is the house dust mite. This allergen is present everywhere. It is an indoor allergen, and it survives more in the damp or the humid environment. It's a perennial allergen. Second is the molds or the fungi, the tree pollens, the grass pollens, the pets, the cats and the dog, and the cockroach. Now, what are the effect of drugs on SPT? Before doing a skin prick test, we have to stop antihistamines at least for 7 days, 5 to 7 days. Tricyclic antidepressants for at least 7 days because they block the H1 receptors. If the patient is on long-term steroids, then the oral steroids have to be stopped at least 2 weeks prior. Topical steroids have to be stopped 7 days before. And beta blocker can affect, if the patient is having an anaphylactic reaction, it can affect with the adrenaline. So beta blocker should be stopped at least 24 hours prior. Now, before doing, informed consent is very necessary as it is an invasive procedure. You have to briefly explain the procedure to the patient, the risks which are very, very minimal, but still the risks have to be told, and the alternative procedure. Now, coming to the selection of the site, the most common site, the most preferred site, rather I would say, it is the upper back as well as the forearm. Now, the first is that you have to start with the negative and the positive control. The negative control, that is the saline, and the positive control, that is the histamine. The drops have to be placed on the skin, and they should be pricked with a lancet. The negative saline, as you can see in this picture, it should be less than 3 millimeter. If it is more than 3 millimeter, that means the patient is suffering from any dermatographism or eczematous conditions. The histamine, it should be 3 millimeter more than the saline. If it is less than 3 millimeter, that means the patient has taken any medications which will affect the test. And in such cases, the procedure should not be continued. After doing the negative and positive control, the allergen extracts which you want to test, they should, the drops, allergen extract drops have to be placed on the skin. Proper labeling should be done. Then they have to be pricked with a lancet. You can use either a 1 mm lancet or a 3 mm lancet. In this picture, I'm using a 3 mm lancet. The lancet has to be placed at 45 degrees angle to the skin. And only there should be a minor lift, that only the dermis has to be lifted. There should be no bleeding at all. If there is a bleeding, then there are high chances of false positive cases. After you have done the pricking with the lancet, after 15 to 20 minutes, you have to see the reactions. These reactions have to be recorded with a measuring scale, and they should be recorded in millimeters. Now, this is a skin prick testing report, and you have to do the reporting in such a way the patient's name, the saline and the histamine has to be recorded, and the size of the wheal, whatever is there, has to be given. So if it is more than 3 millimeter more than this saline or the negative control, so we have marked here the house dust mite are positive. Even the holoptelia is positive in this patient, as well as the cockroach has come positive. The second is the intradermal test. The intradermal test is done only when the patient is having strong symptoms and the skin prick test has come negative, but still you feel that the patient is suffering from allergic rhinitis. In such cases only, the intradermal test is done. However, nowadays, many people don't prefer this test. It is done the same way, same kind of medications have to be stopped, as I've told you for skin prick test. and only 0.01 to 0.02 ml extract is injected intradermally. The reaction is again seen after 15 to 20 minutes and it is recorded in the same way. The difference between the skin prick test and intradermal is that the skin prick test is very safe. The chances of false positive is very low. It has a good very high clinical correlation with the patient. You can do several number of skin tests at one time. The comfort of the patient is very good and it has a good sensitivity. Third is the nasal provocation testing. It is indicated when again if there is discrepancy between the symptoms and the test, your serum specific IG or the skin prick test has come negative, but still you feel that the patient might be suffering from allergic rhinitis. In such cases, it can be done. It can be done in local allergic rhinitis, in where the antigen serum specific IG, that is the antibodies are present only in the nasal mucosa. In dual allergic rhinitis, where the patient is suffering from local allergic rhinitis as well as allergic rhinitis. In occupational allergic rhinitis, and if you have done a skin prick test, the patient is polysensitized to many allergens. So to select the allergen, the immunotherapy, you can do a nasal provocation testing. It is contraindicated when there is acute inflammation of the nose or the paranasal sinuses. Recent surgery of the nose, wait for at least 4 weeks. If the asthma is severe and uncontrolled, the FEV1 is less than 50%. There are severe comorbidities and in pregnancy. The medications to be avoided as the same as of the skin prick test, which I have already told, like the antihistamines, the tricyclic antidepressants, steroids, and even the beta blockers. If you are testing a seasonal allergen, try to do it out of the pollen season. For example, if you're testing for holoctalia, then don't do it in February, March, and April. For perennial allergen testing, do when the symptoms, the burden is quite less. The other prerequisites are that the skin prick test and the serum specific IG has already been done for the patient and it has come negative. The nasal endoscopy should be done to see whether the patient is having any nasal mass or any other polyps. The pulmonary function test to rule out a severe uncontrolled asthma. And there should be an ideal setup for this test so that if any kind of systemic reactions occur, we should be able to manage it. For doing the nasal provocation testing, only the aqueous extract should be used. The glycinerated extracts which we use for skin prick test, they can cause irritation in nasal provocation testing. The test standardization is not available anywhere, but there are still some guidelines given by some papers. The 100 by 100 times dilution is used and a single concentration is sufficient. It can be used either in the form of nasal spray, a filter paper, or a micropipette. Before starting the test, the baseline nasal symptoms are measured in the form of total nasal symptom score or the visual analog scale. The baseline nasal inspiratory flow is measured. Then instill a negative control with the saline. Wait for 10 minutes. After 10 minutes, 0.1 ml of the extract is sprayed on the inferior turbinate. It is done every 15 minutes till the patient shows some symptoms. The subjective as well as the objective measurements are taken. The subjective, that is the total nasal symptom score and the visual analog scale, and the objective, that is the nasal inspiratory flow and the rhinometry is done to see the results. Now coming to the in vitro test, they are the allergen specific IG, now we call it as immunocap, the component resolved diagnosis, the basophil activation test, and the total IG. The fluorescent, this is the immunocap or the fluorescent enzyme immunoassay. This test, it provides an objective measurement of the circulating allergen specific IG antibodies. In skin prick test, we are measuring the bound IgE. However, in this in vitro test, that is the in the immunocap, we are testing the circulating IgE. Extremely low serum concentration of specific IG can be detected through this test. However, higher the level of allergen specific IG antibodies, the higher the risk for symptomatic allergy. And the test report, they should always be interpreted with the clinical history of the patient as we do in the skin prick test. In this test, the purified or the allergen component, it will react with the antibodies from the patient's serum, and they form an antigen antibody complex. After washing away these unbound antibodies, the beta galactosidase labeled antibody, mouse monoclonal antibody, is added to the antigen antibody complex. And the unbound anti-Ig is washed away. The fluorogenic substrate is incubated with bound complex to produce fluorescent 4-methyl umbelliferon. Once the reaction is stopped, the eluate is measured with a fluorocounter. And the detection limits are 0.10 to 100 kilo units per liter. The difference between the skin prick test and the serum Ig is that in skin prick test, we are measuring the bound Ig, where in serum specific Ig, we are measuring the circulating Ig. The results are very quick in skin prick test. We see it within 15 to 20 minutes. However, for serum specific Ig, it can require 1 to 2 days. It is a high skin prick test has a high sensitivity and specificity, whereas it is less in serum specific Ig. Skin prick test is a gold standard test. Serum specific Ig is done only when it is when skin prick test is contraindicated. For example, like in any with comorbidities or asthmatic patient or eczema patients. There is an excellent clinical correlation in skin prick test. There is more scientific patient perception, and there is no interference from the high total Ig. However, in serum specific Ig, if the total Ig is high, all serum specific Ig will also come high. But in skin prick test, there can be interference by medication, which is not there with serum specific Ig. The cost is very low of skin prick test. However, with serum specific Ig, it is quite high. And the anaphylaxis is very, very rare. There are no chances with the serum specific Ig. Now, after doing all these tests, there are still some challenges which we face. Because these aeroallergens, they are ubiquitously present, which makes the avoidance very difficult. Then sometimes there is polysensitization to multiple allergens which belong either to the same or the different families. Again, if your kit doesn't contain sufficient allergens, then there can be again potential misdiagnosis due to incomplete allergen profile. There can be a possibility of cross-reactive because there are similar proteins which are present in different allergen sources, as well as there is interspecies cross-reactive. There is presence of non-allergenic components in extracts. Sometimes even after giving allergen immunotherapy, the skin prick test has come positive, but still the allergen immunotherapy is not giving results, and for a proper clinical decision making. So to overcome these challenges, there is another test which is called as the component resolved diagnosis. Now, exactly, see, when there is any allergen, for example, I've taken in this case, there is a dermatophagoid sterinosinus, which is a house dust mite. It has different proteins in it, that is DERP1, DERP2, DERP5, 7, 10, and 23. So every allergen will have different proteins. So now what we do in a CRD, as we know that every allergen is made up of millions of different types of proteins. For some allergies, there are multiple types of proteins the patient may be responding to. An actual specific protein responsible or a patient reacting to is tested in CRD. For example, here I've given the peanut. Again, it has also a lot of allergens. Now, a cockroach, when we do a skin prick test, if the patient is sensitized to a dust mite, will also may show sensitization to a cockroach as well as a shrimp. Now, the reason is because all the three, they share a common protein, which is the tropomycin. This tropomycin is present in DERP10. It is present in cockroach in BLA G7, and in shrimp, it is present in PEN-M1. So if we do a CRD test, we can actually come to know the patient is sensitized to only the dust DERP10 or to a cockroach or to a shrimp. If the patient is sensitized to DERP10, the DERP10 is difficult to extract, and so AIT is not available. So the patient might not show good results for immunotherapy. So in such cases, CRD is very helpful. This is the CRD test report. This is just an example. Now the third test is the basophil activation test. Again, it is done only when these tests still come negative. It is used to diagnose respiratory, food, drugs, and venom allergies. It's a flow cytometry assay which measures the degree of the basophil degranulation. It detects markers like CD63 and CD203C, and they can be used to monitor the progress of an allergy and predictive treatment outcomes. However, this test is still not available in India and it is quite costly. And it has to be done within hours of taking the blood sample. Total IG is not done in for allergic rhinitis because there was a survey which was done and it has seen that the mean total IG in an Indian population is 550. So there is no, as we are having a parasitic population, so there is no role of total IG in allergic rhinitis. However, if the patient has to be started on omalizumab, uh, then total IG can be of any value. Thank you.
Thank you, ma'am, for a very comprehensive presentation. I would now request Dr. Subir Jain to address the audience on a very important topic that we spoke about during the introduction. So, over to you.
Thank you so much, Anjali. Good evening, everybody. It's a really proud privilege to be here and to talk about recent advances in the management of allergic rhinitis. Why and how this presentation? This is my experience of last 37 years, my way of working, labor and learn before you grow old. Gold and silver may vanish away, but the knowledge acquired will never delay. Life is a constant learning process, and I'm here to share my experience and learn. Going ahead, what you are seeing, this is the miserable condition of a patient who suffers from severe persistent allergic rhinitis, constant itching in the nose, sneezing, rhinorrhea, and these three are the early phase of allergic rhinitis and the nasal obstruction, late phase of allergic rhinitis. So this girl is suffering a lot. And let's go ahead. Allergy. July 24, 1906. So that is a Clemens von Prickert from Vienna. He has given the name allergy. And he was pediatrician and history of antihistamines started from 1937 to now it's 2025. And it started with fenbenzamine, then CPM, then terfenadine, estimazole, cetirizine, loratadine, Avastin fexofenadine in 1996, desloratadine, that is the des isomer of loratadine in 2001, levocetirizine, that is the levo isomer of cetirizine in 2002, rupatadine 2004, and lot of other. Finally, at this point of time, belastin is the final answer, and belastin is the latest molecule which is available. Just 1 second. Yeah. Going ahead, as we have just discussed, it is about the treatment part of allergy as oral antihistaminics and antileukotrienes. It started from CPM, then cetirizine, Avastin, fexofenadine, loratadine, desloratadine, levocetirizine, rupatadine, belastin, and montelukast. That is the antileukotrienes. So these are the drugs, systemic drugs, which we use mostly in cases of allergic rhinitis. Other than this is steroids. Systemic steroids are also there in very severe cases. Even that is recommended in ARIA guidelines. Here comes the belastin, a modern second generation H1 antihistamine, has the highest number of desired properties 10 for a modern antihistamine according to international ARIA guidelines. And my dream for future antihistamine is it should be extended release, because nowadays what happens, if a patient is dependent on antihistamine or he is suffering from severe allergic symptoms, he has to take antihistamine every day, because the maximum duration of action of antihistaminic at this point of time is 26 hours, that is belastin. But if we formulate a new thing, which will be a third generation of antihistamine, and that will be once a week dosing, should not cross the blood brain barrier, because that is our real concern, that it should not cause sedation, because now everybody is so busy in day to day work and their business or their profession or then their school college studies. Nobody wants a drowsy day, so it should not cross the blood brain barrier and should not cause the sedation. And definitely, along with this point, the safety profile of antihistamine is very, very important. It should be cardio safe, hepatic safe, and renal safe. And it should be safe in pediatric age group also. Because nowadays, we see a lot of patients in pediatric age group also of allergic rhinitis. Now, the intranasal treatment of allergic rhinitis, that is intranasal corticosteroids and antihistaminic, started from budesonide and cyclosinide. Then came fluticasone propionate, and at this point of time, gradually mometasone is also came. Then at this point of time, as the fluticasone furet. That is the latest molecule all over the world. 110 microgram daily is the dose. This is a novel enhanced affinity steroid, increased duration of action and retention, and superior anti-inflammatory property. So all these properties are there in fluticasone furet. And the biggest point is only once a day. And intranasal corticosteroid and antihistaminic combination is also there, because intranasal corticosteroids, they take little bit few hours to act, but intranasal antihistaminic, they act instantaneously. Azelastine hydrochloride 140 microgram per spray and fluticasone propionate 50 microgram per spray. This is the combination which is available in the market. And another combination is also with azelastine with fluticasone furet also, and mementazole also. So these combinations are also there in the treatment of allergic rhinitis. The latest things which are available in the market are bioadhesive in intranasal corticosteroid nasal sprays. That is a no drip technology, uses FDA approved bioadhesive polymer which helps to penetrate mucin layer, securing the drop on mucin layer, which in turn increases retention time of the drug. And if the drug is retained more at the mucous membrane, it gets absorbed properly. And if it gets absorbed properly, it works properly and gives very good results. IRRS technology, that is the intuitive repriming free robotic system. What you will see, once a nasal spray is there, and if a pipe is there, it's an old technology. But the latest nasal spray with the latest technology is IRRS technology. It is a blockage free, non return valve at the orifice, maintenance free, locked at the repriming free. Every time you need not to waste the uh, drug, not to reprime again and again. And the compliance is 360-degree. You can tilt the bottle up to 360-degree, but yes, the spray will be there, the drug will be released, and universal nozzle suitable for all age groups. Yes, here would like to exchange my views about the nozzle. What my suggestion is that it should be a rubber nozzle. It should not cause any trauma because the patients who suffers from allergic rhinitis and having a very sensitive nasal mucous membrane, and once the patient they introduce this nasal spray inside and they have to do it, and if it's a little bit hard one, plastic one, that causes little bit of trauma. So why not to have a soft rubber tip on the nasal spray? That is just my very humble suggestion. My research papers on combination nasal spray. When it is long years back in 2010 and 2018, at my clinic, I used to see so many patients. By God's grace, still I see so many patients. And those patients of severe persistent allergic rhinitis with chronic rhinosinusitis with nasal polyposis, twice, thrice endoscopic sinus surgery, FES, functional endoscopic sinus surgery has been done. But still the problem persists. And patients were in miserable condition because of this problem of nasal obstruction. They have to breathe continuously from the mouth. And really, what I felt at that time, just putting intranasal corticosteroid nasal spray in 2010, only fluticasone propionate was there. Furet was not there. And instead of oxymetazoline, xylometazoline was there. So what I tried, I just used to put xylometazoline nasal spray or the drops first, wait for 10 to 15 minutes, let the nasal passage open. And as the nasal passages are open, then I used to advise fluticasone propionate nasal spray to relieve patient of chronic sinusitis and to open the openings of the sinuses, ostia. Ostia opening is very, very important to ascertain the drainage pathway of sinuses. Then gradually that came in my mind in 2018. I presented this my research papers in Asia Pacific Congress and at Singapore and then at Bangkok. In Bangkok, it was oxymetazoline and fluticasone furet combination because I could not see the miserable condition of the patient. And at the bottom, I gave about the future guideline that this combination should be available in the market. And going ahead, I was so happy in 2021. This combination is launched in India. Intranasal corticosteroid, that is a fluticasone furet, 27.5 microgram, and decongestant oxymetazoline, 50 microgram, launched in India in October 2021. And now more than 35 brands are available in India, and they are very widely used. And yes, they are very, very helpful. The main concern about using oxymetazoline for this long period. Different studies are there, and they say that up to 28 days you can use this combination. But to be on the safer side, I prescribe for 15 to 20 days maximum. And all studies are there. Lots of papers has been published on it because the side effects of oxymetazoline, constant and the long-term use is dryness in the nose, rhinitis medicamentosa, atrophic rhinitis. But once this oxymetazoline is used with fluticasone furet, these side effects are not seen, and very safely you can prescribe this combination. Going ahead, my dream about using azelastine hydrochloride. What is the antihistaminic? But what happens? Azelastine is very, very bitter in taste. You would believe once this molecule was introduced in India, I took around 13, 14 CMAs around my state, my hometown, and introduced azelastine and at that time fluticasone propionate combination. But the test was very bitter. And Now, again, this came in my mind because the trigger zones of allergic rhinitis are anterior one third of nasal septum and anterior one third of inferior turbinate. And why not to apply? We can have a brush, whatever the brushes you are using for applying nail polish. Yes, we can use such brushes to apply Azelastine locally on this trigger zones of allergic rhinitis. And I should, means I feel that patient should get a very good results out of that. And this is under research. And again, I'm hopeful that my this research will be of great help to humanity. My God, she is still suffering. We have tried all antihistaminic. I have prescribed her anti-leukotrienes. I have prescribed her systemic steroids. I have prescribed her intranasal corticosteroid. I have prescribed her intranasal antihistaminic also and with decongestant also. But severe persistent allergic rhinitis is there and she is suffering a lot. So, what next? Yes, he said, Dr. Ena, you have prescribed me lot of antihistaminic, lot of drugs with different brand names, but please, now I don't want to have more of such kind of drugs. So now what to do? Yes, definitely, where allergen detection and avoidance is not practical, there comes the role of allergy testing and allergen immunotherapy. At this point of time, all over the world, this is the final answer. And it's not like that I'm saying it like that only. You see, well established guidelines all over the world about allergy testing and allergen immunotherapy. European Academy, American Academy, American College, WHO, World Allergy Organization, everywhere, this is the final answer. So, whenever a patient of severe persistent allergic rhinitis comes to you, please try to help him by allergy testing and allergen immunotherapy. As Dr. Rupali covered it very nicely, allergy Prashnavali. You have to take the history in great details. Devote some time for history taking, and that is going to guide you for the further management and how to go ahead. Lots of diagnostic tests are there. Multitude of tests are there in vivo, in vitro. But at this point of time, skin prick test is the final answer. But as the science is developing every day, what we have seen, see, this is the skin prick test method. What you are seeing in the bottles, these are colored coated allergen bottles. You have to just put the single drop, put the lancet, and readings are taken in 15 to 20 minutes about the wheel and flare response. But past 26 gauge needle was there, intradermal testing was there. The immediate path is 3 millimeter lancet. And now the present is 1 lancet. Absolutely painless procedure. Not even a single drop of blood comes out when we prick by 1 lancet because you did not go too deep. Just you have to put straight lancet into epidermis, tilt it to 40-degree, and elevate and take it out. And you get wheel and flare response. But this is not the allergy test report. This is basically sensitivity test report. Whatever wheel and flare response you see, that is the sensitivity report. You have to correlate with the history of the patient. And the recent advances in allergy testing are molecular allergy diagnostics. That is the fourth generation allergy testing, advanced microarray assay technology. And this is the latter technology, microarray, nanotechnology, molecular allergens are there, protein family, identification, discrimination, artificial intelligence is there in this. And a single run, you can do 300 allergens tests. Total IgE is tested. Controls, calibrations, automated report is there. All kind of allergens, starting from food to latex. Everything has been covered in molecular allergy diagnostics. And purity is there. No cross reactions are there. An automated report. Again, artificial intelligence is affecting our day-to-day life now. Whatever is there, and here also it has come, and molecular allergy diagnostics. So finally, I think in near future this will be there. And this was about the diagnosis of causative allergens and their correlation with the history. But what next? This is the halfway we have gone through, but we have to travel complete. We have to cure allergy. And yes, allergen immunotherapy is the final answer. Since 1911, science is developing and allergen immunotherapy is progressing day by day. Subcutaneous immunotherapy will be immediate fast. Definitely, every time patient has to visit a clinician, wait there for half an hour, and nobody has got this much of the time nowadays. And definitely, sublingual immunotherapy will be present and future also. Allergen immunotherapy, that is a desensitization, is recommended in cases of IgE mediated allergies where avoidance is not practical. So, sublingual immunotherapy is SLIT. Composition and rationale of SLIT: 50% glycerinated buffer saline containing allergenic extract in increasing titer, gradually increasing titers from various allergens. It is governed by individual sensitivity pattern, and history correlation is very, very important. And what is the rationale of sublingual immunotherapy? As the GI tract has an abundant mucosal immune system, so-called gut-associated lymphoid tissue GUT, hence an effective antigen can be expected. Sublingual oral immunotherapy uses the principle of oral absorption. Antigens absorbed through lymphatics reaches submandibular lymph channels. And why sublingual route? That's again very important rationale. Dendritic cells highest number and concentration, increased IgE T cells 37 times more than in skin. So why to go ahead with subcutaneous one? Why not sublingual one? Effector cells, eosinophils, mast cells, basophils negligible in allergic patients. So this is where the rationales of sublingual immunotherapy. This was the final answer how sublingual immunotherapy or any of the allergen immunotherapy works. Rapid desensitization, early tolerance, sustained tolerance, and at the end of the day, immune tolerance. What you are seeing in this slide, immune tolerance is the final answer. If a patient develops immune tolerance against causative allergens, patient is cured. So this is the mechanism of allergen immunotherapy. Sublingual immunotherapy, that is a gradually increasing titers. We start from 1 is to 500, then to 1 is to 250, then 1 is to 150, 1 is to 100, 1 is to 50, 1 is to 20. So these are the gradually increasing titers, and there are different protocols how to take this immunotherapy bottles. And happy to share with you and World Allergy Congress 22 and Asia Pacific Congress 23 and 24 both. I have presented papers on sublingual immunotherapy. I was lucky to be selected for oral presentation at world level and Asia Pacific level. But as the science is developing every day, and you won't believe, my mind goes again and again for something better for the humanity. And as we all are very well aware that sublingual immunotherapy internationally guideline is one has to take for 3 to 5 years. He said 3 to 5 years, and what he has to say. Even if we will think to take any of the medication for 3 to 5 years, it becomes really cumbersome. It becomes really difficult in our day-to-day life. And lots of practical difficulties and practical problems are there. So, 3 to 5 years of slit. Patient refused. Then again, it came to my mind, and I worked on it. And my research is rush sublingual immunotherapy. And this is need of the hour because 3 to 5 years as gradually came down to 18 months. Dosage protocol to take rush sublingual immunotherapy, all bottles, total 9 bottles, 6 bottles, all bottles 5 drops twice a week, numbered from 1 to 6. For example, Sunday and Wednesday, till it finishes. And each 5 ml bottle lasts for 3 months. Initiation phase, built up phase, and maintenance phase. You have to gradually increase the titers. That is the basis and basic of immunotherapy. If you give dosage, very high dosage, then patient develops severe allergic symptoms. So, gradually increasing titers is the basic rule. And the total duration of red sublingual immunotherapy is 18 months. And what you are seeing in these bottles is 1, 2, 3, 4, 5, 6. First 3 bottles last for 9 months. Then last 3 bottles again last for 9 months. So total duration of rush sublingual immunotherapy is 18 months. How to take sublingual immunotherapy, whether it's a rush slit or routine slit, you have to put drops below the tongue. I'm very happy to share, as the life is a constant learning process, you have to count drops properly and put sublingually. What happens? Sometimes the patient report us and say, Doctor, we just put the drops and we develop severe allergic symptoms. Then I ask them, how you put the drops? Just like this. So instead of counted 5 drops, patient used to put more 7 or 8 drops, 10 drops, and they used to develop allergic symptoms. I ask them, better put the drops when you see in the mirror. And what you are seeing my picture, that I'm putting the drops sublingually below the tongue, looking into the mirror. And I just shared with you that life is a constant learning process. Now, one patient came and I asked her, how you take the drops? She said, I just put the drops in the spoon and held the spoon below the tongue. That was something really good, and I learned. And now I advised patient to put the drops down in front of you, put the drops in the spoon, a small spoon, and put it below your tongue. So this is the way we improve, and very again happy. Again, oral presentation at Asia Pacific Congress, Malaysia. My rush sublingual immunotherapy. I presented this paper with the fantastic results. This is the graph, what you are seeing. 40 patients, no symptoms, 12 reduced to mild, 8 to moderate. And this is the result in 18 months. So why not to adapt, accept better things in life like sublingual immunotherapy. Tomorrow's immunotherapy, allergoid. Allergoid sublingual immunotherapy is the allergy vaccine with a carbamylated monomeric allergoid available in tablets and drops. It features an exclusive allergen modification that reduces the allergenicity, contrasting the risk of side effects. This is something future. Omalizumab. These are biologicals. Xolair is a recombinant monoclonal anti-IgE antibody. It binds IgE at the Fc region of the antibody and forms an immune complex. Decreases free or unbound IgE, decreases IgE receptors, approved by US FDA for severe allergic asthma. Subcutaneous injections every 2 to 4 weeks you have to give. The dose is based on weight on serum IgE levels. Biologicals are coming up in chronic rhinosinusitis with nasal polyposis and in allergic asthma. Biologicals are recommended. And what you call as a cluster immunotherapy, along with routine immunotherapy, sublingual immunotherapy, or subcutaneous immunotherapy, whatever you are preferring, you can use biologicals to reduce the symptoms and can give better results. Intralymphatic immunotherapy, this is under process, is one such application route requiring nearly 3 ultrasound-guided injections of low allergen doses into inguinal lymph nodes with 1 month interval. The entire treatment is therefore finished after 2 months. What else you want? But this is under research, and let's hope for the best in the future. Artificial intelligence, future of allergy management, is playing an increasingly significant role in allergy management, offering tools for improved diagnosis, personalized treatment, and enhanced patient care. Artificial intelligence algorithms can analyze vast amounts of data from various sources, including patient records, diagnostic tests, and even environmental data to identify patterns and predict allergic reactions. So, the future will be definitely artificial intelligence is going to help us in the management of allergic rhinitis. My dream about allergy treatment, primary allergy vaccination before allergy march starts. As child is neonate is there with atopic dermatitis, it gives an alarm that this neonate may develop food allergy, then allergic rhinitis and allergic asthma. Neonate to infant to 4 5 years and then 7 8 years or 9 years allergic asthma. As we have got different vaccines for immunization, as we are very well aware about the genotype, genetic predisposition of allergic problems. One fine day, a vaccine will be available in control of allergic rhinitis. Going ahead, these are my humble efforts to create awareness amongst patients and amongst my colleagues also. Humble efforts for creating awareness, 29,300 copies of my written book, Handbook of Allergic Rhinitis, awarded by India Book of Records. This is for patient education. PDF of this Hindi book I have written, and anybody can scan this and PDF can be downloaded. This is in Hindi, and this is for patient awareness. And my humble efforts to create awareness, this is for clinicians who are into allergy practice, how to make allergy diagnosis nearly 100%. And progress lies not in enhancing what is, but in advancing towards what will be. So advancement is very, very important and to progress in the life. Thanks a lot for kind attention. And these were my humble efforts transforming knowledge into clinical practice. Thank you so much.
Thank you, sir, for enlightening us with a very comprehensive presentation. And I would like to ask both of you different questions on the presentation that was conducted. Especially, ma'am and sir, both of you took us across two very important topics related to allergic rhinitis. One is the diagnostic modalities, the other one is the advances in the treatment of allergic rhinitis. So, to start with, I would like to ask Sir that why is the incidence of allergic rhinitis rising, especially in the developed regions?
That's very practical question. What is happening? Basis of allergen immunotherapy, that is the treatment or the cure for allergy, is immunotherapy. And there also we give gradually increasing titers of the allergens. And what happens in a sophisticated world, in the developed country, kids they are not exposed to allergens frequently. All parents are so conservative, they keep their kids, their boys and girls inside the house. They don't allow them to play outside. So they are not exposed to allergens in their developing phase. And that's why they don't develop the immunity against those allergens. Basically, this is Holgate theory, Holgate, Holgate theory. And this theory, and as the India is also now going towards a developed country, so incidence and prevalence of allergy is increasing in India also. So gradually, if a kid or anybody is exposed to those allergens, he or she develops immunity. This is the basis.
There are,
Over to
can
Anjali.
Yes.
can I answer?
Yes, ma'am.
There are other factors also. There's a lot of antibiotic use in the children. You see now, as compared to previous, and then pollution is again increasing a lot. So even the incidence of cesarean section, because the child is not exposed to the vaginal flora. So these are there are dietary factors. A lot of the children, they are now eating processed foods and outside food. So these are some other risk factors because of which this allergic diseases are increasing now in developed countries also.
Yes, ma'am. Ma'am, this brings me to the next question. Like, what is the biggest challenge the clinicians today face in diagnosing allergic rhinitis accurately and how it can be addressed?
What ones? I okay. Uh, the mm, the skin prick test, it is a very, you have to learn the test. I mean, it's not just a test. The selection of the patient, the selection of the allergen is very important. So one needs to learn this test. For that, there should be a proper training program, and then only one can perform this skin prick test or the other tests. They should have complete knowledge of all these tests, as well as even deciding the allergen immunity.
So, talking about the ARIA guidelines, you spoke about that in a very comprehensive manner. Which systemic antihistamines do you consider most effective in the management of allergic rhinitis?
Me or Dr. Rupali?
Uh,
Anjali?
Definitely the newer antihistamines, they are, I mean, the second generation antihistamines or the third generation, they are much more effective. They have a non-sedating effect, like fexofenadine or desloratadine or the belastine, as compared to the cetirizine or the levocetirizine or the first generation antihistamines.
So, your thoughts on this?
Yeah, she's said absolutely correct. And the latest came is Belastine. So even that is absolutely non-sedative. Safety profile is also very good. Duration of action is also very good. And as I covered in my talk, it covers all 10 points about ARIA guideline and whatever the uh, points are there in favor antihistamine should have. So belastin is also there, fexofenadine is there. And for a practical aspect, if we talk, belastin and fexofenadine are practically non-sedative. And if we talk about cetirizine, levocetirizine, they cause a little bit of sedation. So as nowadays everybody wants to be awake, they don't want to be sleepy. So nowadays in practice also, doctors are also prescribing more fexofenadine and belastin. I think Dr. Rupali will agree with me
Yes,
about
sir, yes.
this.
Yes, yes.
Yeah.
Ma'am, coming to another question, like in your clinical opinion, the combination sprays like fluticasone furet and oxymetazoline, how do you think is effective over the other drugs?
When these allergic patients they come, they usually they have a polypoidal mucosa, and they're full of the symptoms are more of a nasal blockage. So in such patients, the combination spray of fluticasone with furoate with oxymetazoline, it definitely works. In such patients, I give them for at least for 10 to 15 days, and then I continue then on plain fluticasone furo. I think sir can tell more about this because he is the pioneer in bringing this combination.
No, you said correctly. Even I'm little bit means the recommendation is up to 28 days, but even I use it for 15 to 20 days. And as the nasal passages are open, after using this combination, I switch over to fluticasone furet alone.
So
Yeah.
this comes to the other question regarding the most definitive long-term treatment approach for allergic rhinitis. If you can throw some light on the long-term treatment.
Long-term treatment, you mean to say you want to ask about the cure of allergy as only immunotherapy? And as my research is there with the rush sublingual immunotherapy, 18 months. So that is the final answer at this point of time.
That is the
So do you
only
think, yes, ma'am.
yeah,
So
no, that is the only
basically, I,
immune modulating therapy available.
Um,
ma'am,
yeah, you're right. Immunomodulation, immune tolerance is developed by using immunotherapy. And that is the final answer what we want. Immune tolerance is the final thing, which is our target.
since we spoke about immunotherapy, now talking about the higher specific IgE levels, does it always correlate to higher allergy or how it should be interpreted?
Yeah, Dr. Rupali,
No,
you covered it.
uh,
Okay, I'll address. Dr. Rupali covered it very nicely that India has got a lot of parasitic infestation. And because of that, lot a lot of patients are having increased IgE, total IgE. And if symptoms are saying that yes, patient is having allergic problem, history is saying that yes, patient is having allergic problem, clinical examination, anterior rhinoscopy, and everything is showing that yes, patient is having allergic rhinitis. So why to go for IgE? I don't think there is no need. And when skin prick test is positive and history correlation is there, so no need to go for IgE when there is a lot of doubt to prove whether the patient is suffering from allergy or not, then and then only in those cases I suggest for total serum IgE. Otherwise, I don't suggest.
Ma'am, your thoughts, your final thoughts on this?
same, no, same. I mean, we never do total IG, at least in cases of allergic rhinitis, no role.
With this, we come to the end of the presentation, and I would like Subir sir and ma'am, Pali ma'am, to share their final take-home message to the audience on the management of allergic rhinitis. So over to you, sir. And with that, we will close the session for today.
Fantastic. And the last you asked very, very practical question. And to sum up the everything, how I sum up at my center, I categorically say to my patients, whenever a patient of severe persistent allergic rhinitis comes to me, I tell them, please control your allergy here only. If you don't control your allergy here, in 35 to 40% of the patient, they develop allergic asthma. 20 to 25% patient, they develop chronic rhinosinusitis with nasal polyposis. 20% they develop otitis media with effusion. So, why not to control allergic rhinitis here? And this is my advice. This is my real humble request to the clinicians that whenever you see a patient or deal a patient of severe persistent allergic rhinitis, please advise them, skin prick test, and better refer that patient to any of your allergy specialist who is into allergy practice and doing skin prick test and immunotherapy. So that is the way we can cure allergy. Over to Dr. Rupali.
I would like to say that there are a lot of myths regarding allergic rhinitis, the diagnosis as well as the treatment part. In especially, I practice in a small place, so the scenario which I see is that there is very poor awareness among the patients, and so I'm trying. I just try to spread the word through this webinar that the physicians as well as the other, even the pediatricians, uh, mm, the chest physicians, they should all try to learn this art of skin prick test. They should take a proper training, and they themselves can then treat this cases of allergic diseases. Skin prick test can even be done in asthma, and allergen immunotherapy has a very good role. And so, why should the patient suffer? So, definitely, I hope after this webinar, there will be an awareness among every healthcare professional, and even they will start uh, referring the patients to the proper allergologist for the patient's benefit. Thank you.
Thank you so much, ma'am. With this, I would like to propose a vote of thanks to our esteemed speakers, Dr. Rupali Patil Jain and Dr. Subir Jain, for sharing their deep clinical insights and practical diagnostic perspectives and evidence-based guidance on allergic rhinitis. Your clarity has truly helped us understand on what, why, and how to address the allergic rhinitis. To all the participants who have joined us live on YouTube, we hope that it was a very meaningful and an interactive session. And to just share with you that this will be available as a recorded session on YouTube, and you can watch it at your convenience at any given point in time. Thank you so much for joining in. Thanks a lot.
Thank you so
Thank
much. Thank you.